you've identified hospitals in the region that have psychiatric care facilities or wards. Have you spoken with them beyond alerting them to the existence of an RFI? The reason I ask that is I'm wondering what sort of response have you received? Are they anxious to go into business with the state in this regard? Number one, that they have facilities available to do it. Number two, do they want to do that given the state's ability to pay its bills on time? And so I'll just leave it at that if you answer those questions.
First, to go back to Representative Coastal's question, was just told that we can adjudicate a claim in 2 to 3 days. Yes, the hospitals that we've listed have expressed some interest in contracting with us to provide these services. They have, before we went into the procurement process that we're in right now, but before that, they obviously wanted to see the contract language and the specifics before they made a commitment. Now we're in the procurement phase, and we really can't, we're limited in the kinds of discussions we can have for people who potentially may be submitting proposals. We'll know more, obviously, after the 20th, but we're very optimistic that there are hospitals in Region 1 South, and also hospitals in Region 1 Central, who are willing and have capacity to provide acute inpatient bed. Yes.
So is there a goal in place, and maybe that becomes clear after the 20th, that you'll be able to say at any given time, we have access to 100 beds, 75 beds, 200 beds at area hospitals? Will you be able to get to that point sometime this spring?
Yes.
And what if you can't? What if some of these hospitals look at the request, determine that it's not financially feasible for them, that they do not have the facilities available, or that they don't want to fight the state for payment, and you have fewer than 100 beds, fewer than 50 beds? What happens to the displaced patients who are currently in inpatient care at Tinley Park if those beds aren't available?
Well, let me first say that I sincerely hope that doesn't happen, because the real philosophy behind this is to allow people to get care closest to their communities and best integrated with other primary care, healthcare, and human services supports. So I'm really hoping for and working for a plan that allows people to get the care in their community. If that's not possible, we will purchase bed days where we can, and the state hospital system in Region 1, that is Madden and Chicago Reed, will have to continue to provide a safety net for those individuals. It's not an ideal situation because it would involve people from Region 1 South traveling, not considered to be a tremendous distance to get care. It doesn't allow for them to have kind of contact with their family and community, and it would really be, I think, very unfortunate. So we're really hoping that providers in Region 1 South are willing and able to do this business. And we're very, very confident that they can and will.
And do you anticipate there'll be some point this spring where you can report to us how many beds, and I don't know if this is the proper terminology, that you have under contract, so to speak? Will we be at that point sometime in the next couple of weeks?
Yes, sir.
Another point on that, how about security? I think that there's a general notion that Tinley Park provides a pretty secure setting for individuals who could be dangerous, are dangerous to the general public. How about at these different hospitals? What sort of provisions, what sort of safeguards will the state have in place to make sure these are secure facilities? These are hospitals in neighborhoods, some of them in very densely populated areas. how can we be sure that when the state sends a patient to these facilities, that that patient will be secure?
Well, first, Representative, I would say that Tinley Park is a minimum security facility. It is a locked facility. Most psychiatric facilities, even community-based psychiatric facilities, are locked. The population of patients served at Tinley Park, therefore, are not our most dangerous patients. As you may know, Chester is our maximum security hospital, and the patients with the greatest propensity for violence or aggression are transferred to Chester. The patients that are hospitalized at Tinley Park are diagnostically and behaviorally no different from individuals admitted to any other psychiatric hospital. There are safety and security concerns, but they, in my opinion, don't exceed those that one would have in a community hospital. If it turns out that there are some considerations that we haven't factored in, we do continue, like I said, to plan to continue to meet with our subcommittee, and that's something that we can address. But I think it's important to emphasize that the patients served at Tinley Park really are no different and are not our most violent patient population.
One other point, I know one of the plans or some of the materials I've read, there's been talk about a mobile crisis response team of some sort. Can you describe exactly what that entails, how they'll go into action, what kind of scenarios they would be called into action for?
We actually initially thought about that and modeled it after the very successful mobile crisis response team that I believe is in place in Milwaukee. As we began meeting with our providers and talking with advocates and stakeholders, that didn't seem like something that would actually work for Region 1 South. We decided to go with crisis outreach that didn't necessarily have the mobile component, and that is maybe, for example, either co-located in a community mental health center or ideally co-located in an emergency room to provide on-the-spot emergency assessment, stabilization, and linkage. So we initially thought we were going to go with the mobile model, but as we thought about it and as we got input from others, we really decided to go with an outreach model.
My concern is someone who, from criminal justice background, working with the county sheriff's office for years, is we've seen this state and other states around the country sort of recede from institutionalized mental health care. We've seen an added burden placed on the criminal justice system. We see it every day. I saw it when I worked with the sheriff's office at Cook County Jail, which is commonly referred to as the largest mental health facility in North America. It's anywhere from 1,000 to 2,000 individuals in the daily inmate count there are receiving some sort of mental health treatment, whether it's actual counseling or medication. That's my biggest concern in this proposal, is that we're going to continue to see a shift to the criminal justice system, whether it's county jails or the state correctional system down the road. What can you say to assure individuals in the law enforcement community, police officers on the front lines, and to people in the institutions as you go up the chain of the criminal justice system, that this is not going to, Tinley Park closing is not going to add to their burden?
Well, the first thing I would say is that I share your concern, and that it's equally unacceptable for us in the vision of mental health that persons with mental illness are incarcerated and don't have access to care. What I can tell you is that our focus of trying to enhance the crisis system, and the crisis system in EDs in particular, is in fact due to our sensitivity to the issue of not having people with mental illness go into the criminal justice system. By enhancing the psychiatric emergency response in EDs, we want to make sure that if law enforcement brings somebody into an emergency room, they have somebody to assess them, to stabilize, a place to stabilize them, and a place to link them, and that the default would not be for county jail. That was the thinking behind an enhanced and expanded crisis system and focusing it primarily on the emergency department.
Right, and that's why I asked about the mobile crisis response team, which seemed to be somewhat promising to me, because I think the scenario you just outlined happens all the time. The police agency brings someone with a mental health issue into the emergency room. That person is often stabilized and put back out in the community, maybe with a packet of medication, only to reoffend, and either reoffend because of their mental illness, or because that's the only way to get any sort of services, that they have nowhere else to go. I'm not sure I see in this plan a fix to that problem, and that problem exists actually whether or not Tinley Park stays open or not. That's a problem. Well, what is the department going to do if there is going to be added monies available now that the institution's no longer going to be there? How can some of those dollars be reinvested to act as a stop right there on the front lines, which really is the emergency room, where we can say to the police officer, okay, we will handle this. We don't want this handled in the criminal justice system. We want it handled in the mental health treatment system. So, and I'm not sure that I see in this proposal anything that's really terribly different from what's going on right now.
Well, I think it is different in that once the person comes into the emergency room and they're identifying somebody who potentially could have gone to Tinley Park, they won't just get medication and be turned back out on the street, but they'll have linkage and monitoring and follow-up and all that goes with that. So we really are trying to focus on those 1,900 people who would have gone to Tinley Park and ensuring that we have services, supports, linkage, follow-up, all the entire array of services in place to ensure that people don't end up in the criminal justice system.
Let me just add, if I can, Representative, I really applaud you for your question and your focus on that, because we have to approach this from a variety of perspectives. And another one in the human service area is the Medicaid program, and Director Hamas at the Department of Health and Family Services is simultaneously working with another group of General Assembly members on cuts to Medicaid, but we're looking at where that waste occurs. And there's a tremendous amount of waste in the inpatient admission of people with often substance abuse problems, for which we pay $5,000 to $10,000, and they leave a few days later look better than they were, maybe sober, but not having had their condition addressed. And so we want to link that Medicaid effort to the focus of the department, the Division of Mental Health and the Division of Alcohol and Substance Abuse, so we can really look at this comprehensively and not from the perspective of which payment fund the payment is coming from. But it's a big problem that exists today with Tinley Park, and we think that we're motivated to solve that problem, and we think that these components of the plan will help us get there.
Thank you.